Hi James and hi Anthony. Thank you for giving us this opportunity to transmit again from AIG. Over the next 40 minutes, we have 3 cases which we'll quickly try and finish. We have, of course, along with me, I have Dr. Santosh, Chief of Anesthesia. All of you know him. And Mr. Srinivas, a technician. The first case is a simple case for demonstrating an ERCP technique. The second is GERDEX and third is a radiofrequency ablation. So 3 cases quickly. So this was a 51-year-old male patient who presented with recurrent episodes of fever and pain abdomen and jaundice of 2 months. LFG showed an obstructive pattern and ultrasound and MRCP confirmed cholelithiasis and stones in the CBD. He had attempts at ERCP elsewhere but couldn't get it done. So the technique here is to demonstrate, if possible, selective cannulation of CBD to see if we can get these stones out by standard technique or whether we have to use some sort of lithotripsy technique. So this is just a paper that we recently published on the clinical utility of ESG and ASG guidelines, and in our opinion, the ESG guidelines are superior to ASG guidelines in those with intermediate risk. Okay, so we go to the case. If you can show me the endoscopy picture. So I'm already in. I'm using an Olympus 180 side wing scope with a 4.8 channel. The papilla looks a little edematous. He was another hospital earlier, and I think they have made attempts there. I'm using a clever cut spindletome from Olympus. Of course, we always cannulate the Olympus spindletome, and I'll try and direct my spindletome towards the biliary duct. So what happened was, I think the edema is probably because of previous cannulations attempt. So I'll just put my spindletome, flex it a little, and then go towards 11 o'clock. You can see what I'm doing. I'm just turning my scope a little so that I'm facing towards the CBD direction. And then you see the wire is hitting against the wall. It's not going in easily. Now I'll just relax the spindletome a little and now it's gone in. Are you getting the fluoroscopy picture?
Yes,
James?
very nicely.
Yeah, so now I'm deep inside. So let us inject and see what happens now. Can you inject some contrast? Srinivas injecting contrast. We are injecting undiluted contrast here. I just come down. Yeah, now you can see the stone. There's fairly large stone there. Can you see that?
Yep. Yes.
A nice stone. So I'm going now to do a sphincterotomy, but I'll also do a partial sphincterotomy followed by sphincteroplasty because the stone is about 12 millimeters or maybe 13, the size of the endoscope. So it won't come out in the standard sphincterotomy. Huh? Yeah. So what we'll also do is, we'll do a standard sphincterotomy up to about half of the papilla or 3/4 of the papilla. I'll follow this up with a sphincteroplasty using a TTS balloon. And then after that, hopefully we get the stone out. If we can't, then of course we have the option of a mechanical or a spicolangioscopy. Okay. Now we come out back. Now the technique of sphincterotomy, again, for those who are starting ERCP, is to have your papilla in a nicely distant way so that you're very comfortable. I'm using a clever cut sphincterotome, so therefore 1/3 of the sphincterotome is not covered by a plastic sheath, only that part is inserted. My assistant has bored the sphincterotome to give it a little tension. I use the elevator to pull it up, and I'm using the shaft of the endoscope to direct my sphincterotomy. See this? This is how, so that I'm in a stable position. And as I cut, I'm going to pull my endoscope back. I'm pulling the endoscope back. I'm using an endocut current and frequently keep assessing how much you are cut. So now you see that cut is going a little in a direction which is not too optimum. So I'm correcting it and coming back to 11 o'clock, 12 o'clock position. I'm cutting again, cutting. I'm seeing very little movements here. Just the shaft I'm holding. This is an endocut current. Okay. So I think I cut sufficiently now to put in a balloon to dilate rest of the segment. The reason why we use a balloon more often is that we find that in a stone like this, when you try to get it out without a balloon sphincteroplasty, the stone gets stuck in the lower end and you get impacted. So the important principle is to try and push the stone up into the bile duct. Otherwise, the balloon will wedge in between. So I'm going to use a standard TTS balloon and push the stone up a little and then do the actual sphincteroplasty. You agree, James, or any other? You are the guru, you must tell me.
We agree.
We agree.
Okay.
What size of a balloon would you use?
Yeah, so we'll use a TTS balloon which goes up to, no, TTS balloon, which goes up to 15 millimeters. Normally, I never dilate beyond 15 because the chance of a perforation gets higher beyond that. So only maximum of 15 millimeters. This is a fairly big duct, so I think I should be okay with 13.5 to 15 millimeters. But the important thing is to push this stone up. If I don't, then I'll sort of have a problem getting this stone out because it'll get impacted into the wall. So I'll follow it fluoroscopically and see what happens as I try and push the stone out. This is the TTS balloon going inside. Fluoro, please. Now we'll see if we can push. Yeah, I'm trying to push the stone up there. It's not going completely out. One of the tricks then is to do a partially inflate the balloon, and with the inflated balloon, push the stone up. Yeah, that's enough. That's enough. Now I'll push the stone. See this? How the stone has gone a little up. And now, yeah.
You do not use contrast in your balloon?
No, we are using contrast, but I partially inflated it only, just so that I can push the stone up a little. And then now I'm putting in some contrast and inflating the balloon to see if the waste goes off completely. Yeah. Huh? Yeah. Deflate a little so that I can go in a little more. Yeah. Now inflate. Yeah. So now you can see the waste that's coming up, but I have to make it straight. Can you see the waste now?
Yep.
James, you're happy with the waste?
Yes. Yes. And
so Anthony may want to remove this with using an endoscopic ultrasound. I don't know, you still have the technologies for that now. So now we are dilating it further. I want the waste to go further. Yeah. Little more. Yeah. I think the waste is gone. Stop. Now, Hanta, how much? 13.5. We keep it for a few seconds.
Okay.
Usually 30 to 60 seconds. There's no data to say how much.
Yeah.
But we do it for about 30. Workshop 30 seconds, normally 60 seconds. Because workshop, everybody gets restless.
Well, there isn't really a stricture, so that's not a strong indication to have it for.
Anthony, we're not able to hear you well.
we noticed that you also push the scope in to make sure that the balloon is, the alignment of this balloon is along the alignment of the duct.
Yeah, that's the important point. You should be in the alignment towards the CBD. That's very important. I think we can stop now. So we'll stop now. We'll leave the balloon in place and quickly put a stone extraction balloon so that we can get this thing out. Yeah. So now the important thing also to see that you have to completely withdraw all the contrast and saline using a regular syringe. Otherwise, it don't come out. Usually, some amount of bleed that you see here, it's some amount of ooze that occurs, but doesn't matter. Okay, so we leave the guide wire in place, and we don't bother about what's happening in terms of bleed, but you know, our bleeds are actually much less than what you've seen with zoo. The very benign type of.
Yeah, so since the CRE balloon is there, I mean, you can always reinflate the balloon.
Yeah.
But most of the time, these bleeding will stop by itself. So
they stop by themselves. Yeah. We also use a spray called Temsil spray. It's a fibrogen spray at the end of the procedure. Here, this is available in India now.
Okay.
It causes a lot of fibrin material to come in and sticks there with the bleed. So now we put in a standard stone extraction balloon, and this stone extraction balloon is up to, again, you can inflate up to 15 millimeters.
So Nagi, have you experienced any post-sphincteroplasty perforation?
Yeah, so if you do above 15, the chance of perforation, but even that is less provided the duct is big. If the duct is small, then your chances increase. So now I'm putting my balloon right up there, the stone extraction balloon, inflating, getting it down, and then we can inject some contrast also. to see what's happening. Okay, right. Now I'm coming down, inject some contrast. So, right, so the thing is above normal. So, what I'm going to do is I'm going to use a technique which is very important for teaching purposes. I'm going to fix both up and right knobs, hold the balloon with my left hand, the balloon sheath, and then push the scope down and turn right. So, this way I get the stone out in the axis of the CBD. So, this is how it should be done. Yeah, now, yeah, you can see the stone out. Okay?
Very nice.
Yeah, very nice. Masterly demonstrated.
Thank you,
demonstrated by the master.
Masterly demonstrated by the master.
So what we'll do is, meanwhile, because this is over, we'll go on to the next room where Rakesh is ready with a GERD-X patient.
Okay.
Thank you very much.
Thank you.
Thank you. Thank you.
Hi, Rakesh.
Hello. Hi, Anthony. Hi, James.
Hi.
So thanks for the opportunity. We'll move on to the next case. So as you see here he's a 44-year-old male with predominant high volume reflux GERD, and his investigation showed high volume reflux of 154 reflux episodes with a high demister. So the plan in this case is to do a endoscopic fundoplication, and the device name is GERD-X. It's a gastric fundoplication. This is a recently published study from our group, which is a randomized controlled trial in gut, where we have compared it with the placebo arm and found significant improvement in the quality of life index and also partial improvement in the PPI dependency. So coming to the case as such, I'll just show you how this GERD-X device looks. So this is a device which has got a couple of components which one has to know. I'll explain you. It's got a shaft which is around 17 to 18 mm thickness in diameter, and also a handle which is used to hold and navigate the device. Couple of components on this handle. You have fire, close, and open mode with a wheel which is used to flex and retroflex the device as you see it on the screen. And also you can lock the device. Then there are two channels in the device. One is for the helix to enter and grab the tissue. And the second is another channel through which a pediatric scope is passed to navigate and then show us the direction on which we are going. And as you see here, once I go into the open mode and then open this, you can see these two are the distal end of the device, which has got two prongs. With these two are used to fit the pledgets, the sutures, and then mount it. I'll show you how we load the pledgets also. So I'll now, for want of time, I've already intubated the patient. And as you see on the endoscopic screen, so you can see on the external camera here, I have put in the device inside the patient mouth. The patient is intubated. I have Dr. Asif, who is going to be my third eye as an operator who will assist me. Dr. Harnath is our anesthetist who has done a good job of doing a general anesthesia on an intubated patient, and I have Madhu and his team assisting me. So now you can see the device is intubated inside, and you can see the pediatric scope, which is going through the side channel of the GERD-X scope. So what I'm going to do now is go nearby both. Can you show them fluoro picture? I think you can see the fluoro picture there.
Yep.
Both my device and the pediatric scope are retroflexed.
Yep.
So now I'll go to the open end as you see on the screen, and then open the pledgets device, and then I'll try to see. Usually we take the criteria of Hill's 1 or 2 patients with small hiatus hernia. So in that way, usually 2 sutures are suffice for this. So what I am to go do now is go and position myself towards the lesser curvature. And once I am here, I lock. And Asif, can you just rotate the device so that they can see the helix coming out? You see here the helix has come out. And now I'm doing 3 or 4 clockwise rotations, then taking the tissue inside the 2 prongs. And now I'll go to the close mode and adjust myself so that I get good amount of tissue and close the 2 prongs. So once I close the prongs, as you see my hand movements, I'll go on to the fire mode and then press the fire button. So the beauty of this device is once you press this lever 1, 2, it gets automatically locked. That means the suture is deployed. So once the suture is deployed, I'll go to the open mode and I'll unheal the helix, get the helix inside. Can you close? And now I'll open the distal end and then I'll gently push in. Let me just, so I'll redo it and then, so I'll open. So the helix has caught, okay. So now I'll open the two ends. As you see here, the suture is being deployed. And now you can see the suture which has formed a small wrap kind of thing. So that's the first suture being deployed. Now I'll target myself onto the greater curvature. So what I'm going to do now is under fluoro, Asif, can you just neutralize your scope, neutral the scope? Yeah. So now Asif will pull the scope out. I also have made the device straight as you see it on the, can you show them the fluoroscopy screen? Fluoroscopy, please. Yeah. So now I'll gently pull out the device. So this is the first suture being deployed. I'll now show you what I'm going to do for the next step of second suture. I've used a simple same pediatric scope. I'll go in and then get into the post-pyloric area. Now with this scope inside the duodenal bulb, I'm going to push in a guide wire, which is a metallic guide wire, which is an inbuilt guide wire with the device. This is just like our Savary-Gillard guide wire. So I'll push the wire into the first part of duodenum, leave it there, and pull out the scope. And this wire is used for railroading the Gerdex device inside for the next suture. So as you see here, I am taking out the same pediatric scope and I'll use it again to get into the device. Can you hold the wire, please? Okay. So now I'll show you what I have done before I intubated. So on this guide wire, the Gerdex device, can you just show them my fingers and hands? So this is how the guide wire is pushed into the device. And then you have to put your finger and then elevate the guide wire, then push it through and through the Gerdex device. And once you start railroading the device on, the wire comes on to the other end at the handle area. And now I'll hold the device. You can see my hand movements. And we'll just put in some silicone gel for good lubrication. The safety part of the device is the pledgets are made of silicone, so there is no chance of injury of the mucosa. Can you concentrate on the patient's mouth? So as you see here, my anesthetist is giving me a support of extending the neck, and you can show them the fluoro. So you see on the fluoro, the device is nicely pushed inside the stomach, and once you see the gastric shadow, then I'll come to a neutral position as you see my hand movements. And Asif is irrigating the channel with normal saline so that he can push in that pediatric scope. And another important, very simple part is I'm using a sphygmomanometer cuff to inflate so that I get enough amount of room when I go in and be in a retroflex position. So now Asif is pushing in the pediatric scope through the channel in the Gerdex device. Yeah, please push in. Okay, now he has shown me the distal tip of the device. Along with me or along with him, I'll retroflex the device and then go deep in. So now as you see here, my target will be, can you just inflate, please? I'll open up the prongs and now I'll position myself so that I'll get good amount of, just keep inflating. I want to have a better view. So I'll try to go as far as possible towards the greater curvature and then try to put the second suture. Can you push in the scope, Asif? Yeah. So now, as you see here, now I'm in a better position. So I'll push the helix out and then make 3 or 4 rotations, catch the tissue, and it will be locked. So now with this position where my helix is catch the tissue, I'll go to the closed end and then try to see if how much of tissue can be grabbed. So I'll redo it again because I'm not very happy with the tissue. So the advantage of this is you can position yourself and then see how much of good amount of tissue you can get. So let me lock it. Okay. Yeah. Now I'll go to the closed end. No, you have to show me. Yeah. So now you see. Okay. So now we deflate, please. Okay.
So you are at the same time trying to close the defect. I mean, make it tighter. The OGJ.
Sorry, Anthony, I couldn't hear you. Can you repeat, please?
Are you at the same time trying to make the OGJ tighter?
Same time?
Trying to close the free space. There's a bit of a hiatal hernia right there, right?
Yeah,
the flap is a bit loose.
So yeah, so it hurts it because this is a gastric fundoplication, unlike the esophagus. Yeah. We are going to address only the gastric area. As you said, because we are going to choose only the small hiatus patients. So we are not going to really exactly repair the hiatus hernia, but going to give only a gastric plication, fundoplication.
So you close the jaw before you use the helix, right?
Sorry, I'm not able to hear you, Anthony.
Okay. I allow you to work. Sorry.
Oh, how long it works? Okay, sorry. So the we have a follow-up of around more than a year with the patients in our trial, and now we are entering the second year. So fairly around for 2 years, what we have observed is we have sustained improvement in symptoms. Can you just open it? Straighten it. We have sustained improvement in the quality of life and also PPI independency around 70 to 80% at the 2-year follow-up. We need to have a longer follow-up, but as of now, for 2 years, the results are sustainable. Can I have apogee scope?
So how many sutures do you need to place?
Usually 2 are enough, Anthony, because we are choosing a case who has got Hill's grade 1 or 2. So 2 will usually suffice. If it is Hill's grade 3, then probably we go for 3 sutures. Okay. But in this, I think we'll stop at 2 sutures because it's a very small. Okay. I mean, it's in a Hill's 1 or 2, Hill's 2 grade.
So you are really just trying to make the EGJ a bit tighter, right, with this device?
No, sorry, I couldn't hear you.
Thank you, Rakesh, for that excellent demonstration. I think one more short case we have very rapidly because we just have about 10 minutes for us for demonstration.
Sorry. Okay, go ahead.
Okay, Anthony, this is, I think, another very fast case. So this was an 80-year-old male patient with obstructive jaundice and weight loss, multiple comorbidities, unfit for surgery. Lab showed obstructive jaundice. The ERCP showed breast cytology with adenocarcinoma. MRCP, you can see very clearly that there is a tumor at the junction of the hepatic duct and the common bile duct, just as the cystic duct is entering. So the plan in this case is to do a radio frequency ablation and then, of course, try and put a stent in this patient. What I've already intubated so that this is a study, of course, which showed a randomized study showing the difference. I know that Prince of Wales also is working in this area. What we are going to demonstrate is this is the catheter, radio frequency catheter that we use. This is an ELRA catheter which comes from Taewung companies. There are 4 steel electrodes between which this bipolar current flows through, producing energy which is about 80 degrees, 75 to 80 degrees heat. Now I already put my catheter inside, and if you can see the this is the ERCP film, but if you can see the present film, Anthony, can you see the fluoroscopy now?
Yeah.
You can see my catheter. I have placed those steel rings exactly at the site of the stricture, which is about 2 centimeters. I get a burn of about 2.5 centimeters with this. And if you can look at the generator, with generator, the very important aspect of the generator, the temperature control, you can see that the wattage can vary, although we put it at 10, but the temperature should be constantly maintained at around 70 to 75 degrees. The time is for 2 minutes. And also look at the impedance. Impedance is again maintained very closely below 50 in this case. Impedance goes very high. That means contact is not proper and it stops automatically. So the important thing about this machine is the temperature control compared to the earlier Habib machine we had. Temperature should be between 70 to 75, maximum 80, not more than that, because if you go beyond 80, you tend to char. So you see it's 1 minute over, but what is important is if you look at the wattage, how the wattage actually varies a lot. It can go from 11 to 0 and still the temperature is maintained. So if you keep a constant wattage, then charring will occur and the actual process is not proper. So I think this is a very important aspect of radiofrequency ablation, which most endoscopists are not aware of, and this should be kept in mind. It's also important that when I'm doing this procedure, my catheter is very still. I'm not moving my hand, it's absolutely still here. And after the ablation is over, we give about 20 to 30 seconds for the catheter to cool off. Otherwise, if you pull it through the channel, sometimes we can damage the channel. So these are certain principles of radiofrequency ablation. In our unit, after the radiofrequency ablation, we always put a self-expanding metal stent uncovered. Whereas there are units which put plastic stent and repeat the RFA after, say, a few weeks. We don't do that. We give only a single RFA. Of course, we haven't compared it with photodynamic. I think PDT we don't have, like you have PDT. We don't have, so we don't have the comparison. But I think for us, we don't have a randomized study, but this has become a routine practice in our institute to use it following the studies that came. Okay. So now the 2 minutes is over, just 20, 30 seconds, and then I'm going to remove this electrode. Yeah. So the wire is kept in place, and for stenting, I'm planning to use an evolution biliary stent uncovered. The question is 6 or 8. I think in this case, 6 should be enough. Huh? So Anthony, my technician is saying 8, I'm saying 6. So we have a little disagreement. But it doesn't matter. Maybe you can err on the bigger side because the workshop, he has to be very careful.
How about in patients with tumor ingrowth? Do you apply radiofrequency for them as well?
Yeah. So for those who have tumor ingrowth, we have used radiofrequency. But the important thing there is that you will use a catheter which has only very short, that is only 2 strands. If you use the longest one like this with 4 electrodes, it tends to have an high impedance, and wherever it touches the electrode, touches the stent, it tends to get shut off, the impedance by. Okay. So this is the evolution stent uncovered that I'm using. You can see it's going through, and then it's a little longish than what I wanted, but doesn't matter. Okay. Now we'll ask our technician now, Srinivas, to use it. You can see the handle here, right? This handle is like a gun.
Yep.
What he does is he's going to fire this, and then as he's doing this, watch this red strip going on the top. It comes to a point here called the point of no return. At this point, we can't reconstrain the stent. We would then pull out the back knob here, and then the stent can be completely deployed. Okay, Srinivas, start.
Okay.
The other important thing is to watch both fluoroscopically and endoscopically. Stop. At the endoscopy, you find right at the bottom here, you'll find an yellowish, can you make that out, Anthony? The yellowish discoloration of the end of the stent?
Yep.
Yeah, that indicates the end of the stent. Can you keep deploying now? Now, Srinivas is deploying, and I'm gently pulling back, pulling back, pulling back, pulling back, and he's now come to the point of non-return. You can see this here, the point where it doesn't return. The camera can focus here. Yep. And at this point, now everything is final. Once you release it, it's going to get released. So it's going to release it now. Release, 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 release. Okay, release, release. Now, yeah, now he's going to release it, and now it's released completely. And what is very important, see the thread hanging there. Now, if you remove it completely, that will come off back. So what we'll do is remove this knob here. Yeah, remove the knob. And once you remove the knob, it gets dislodged. See that? The thread gets dislodged. And then, of course, you can remove the inner catheter, and the process is done. Okay. And then I think this patient with this RFA stent, you can already see fluoroscopically it is expanded well. I'm sure he'll get a good benefit.
Thank you very much. Very nice demonstration.
Thank you.